Hello and welcome. I'm Melanie Hayden of the Healing Cocoon and Massage Therapy Radio, and I will be your host for this discussion with my very special guests, Ruth Werner and Diana Thompson. Ruth Werner, also known as the Pathology Queen, is an award-winning educator, longtime writer, and retired massage therapist with a passionate interest in massage therapy research and the role of bodywork for people who live with health challenges. Her groundbreaking textbook, A Massage Therapist's Guide to Pathology, was first published in 1998 and is now in its 7th edition, published by the Books of Discovery. Ruth is a columnist for Massage and Bodywork magazine and Massage New Zealand. She has served on several national and international volunteer committees, and she teaches continuing education workshops in research, ethics, and pathology all over the world. She hosts her blog called The Path Queen, that you can find on her website. And welcome to Diana Thompson. Diana has been practicing for over 30 years massage therapy, and her practice is currently in Seattle. She loves treating acute and chronic pain disorders, and that's really her specialty and her passion. Diana has received many awards, including the President's Award from the AMTA, Massage Therapist of the Year from One Concept, and Humanitarian of the Year recognized by Performance Health. Her newest endeavor, Hands Heal Electronic Health Record, turns her book, Hands Heal, Communication, Documentation, and Insurance Billing for Manual Therapists into an online charting system. Diana has written the book, Integrative Pain Management, Massage Movement and Mindfulness-Based Approaches. Her book was published in 2016. What's really cool is that both Diana and Ruth are former presidents of the Massage Therapy Foundation. So we have some really great talent here and some incredible experience. So just before we get started, I wanted to just share a little bit about my background as well. I've been practicing massage therapy for over 25 years, and my practice has always been focused on health and wellness and providing my clients with resources to support and maintain their health and well-being far beyond the massage room. I've created and hosted professional conferences, local retreats called the Urban Girlfriends Getaway with speakers on health and wellness, and have over 13 years experience bringing educators and students together into a virtual classroom like this as one of the co-founders of the World Massage Conference. So today I am merging my technical skills and passion for sharing wellness resources by engaging in this discussion around the massage profession and what that's going to be like leading back into our practices after the COVID-19 lockdowns are lifted. So I just want to welcome Diana and Ruth to the Healing Cocoon and Massage Therapy Radio video podcast.
Thanks very much, Melanie.
Well, I also want to just kind of frame this that it really is a discussion, and we're in the middle of April 2020. We are about 5 weeks into kind of this global lockdown. And with massage and bodywork professionals, and as well as other manual therapists from all over the world who are not currently able to practice or are practicing very minimally, depending on where you are. So what I thought that we needed to do was start looking at what is it going to be like for us to get back to our practices, because things are going to change. And we may get direction from our local government, from federal governments, from our organizations, our regulatory bodies, our licensing bodies. But for now, we just wanted to start this as a discussion so that we can start thinking about that and getting excited to get back to practice. So Ruth, I'd love to start with you, and let's talk pathology of COVID-19 and what that looks like, and maybe talk a little bit about why it's so different than even a really bad flu season.
Okay, I'm happy to talk about that, thanks. I'm a little bit tangled going into this because there is so much information that changes radically, almost from one day to the next. And I hope that listeners to this podcast will, are able and willing to go and look at this further on your own. What I can say is it's a different group of viruses than flu viruses. The coronaviruses and flu viruses are just two different sort of groups. There are gazillions of coronaviruses. Many versions of the common cold are related to certain kinds of coronaviruses. We have seen other much more deadly coronaviruses before, and particularly in Canada, you had a much bigger interaction with SARS than we did in the States. SARS and MERS are examples of previous coronaviruses. What makes COVID-19 different is we have never seen anything like this. And so no one in the human race had any kind of protection to this. It's a novel virus. That's part of its delineation. It is far more contagious than flu, although there's controversy about how contagious it is. But a typical flu virus, a person who has flu and is in normal day-to-day communication or contact with other people will probably share it with about 1.2 to 1.3 other people. We call that its R value. And with COVID, that's more like 3 to 6 people. So it's much, much more contagious. And its mortality rate is hard to determine because we don't have good testing. At this point, the mortality rate looks really high because the only people being tested are people, at least in the United States. That's all I can speak to. I really don't know what the situation is where you are, Melanie. In the United States, almost the only people who are being tested are the people who are sick enough to have to go to the hospital. So it's probably on the order of something like 10 times more people who have been exposed to this virus than who have been diagnosed with it. And the good news part of that is that the mortality rate is probably not as high as it looks because, all we can do is compare to the number of people who die to the number of people who have been diagnosed. But that diagnosis rate is probably falsely low. I hope that makes some sense.
Yes.
In any case, the mortality rate is much higher with COVID than it is with flu. We have no vaccine for it. We have no treatment for it. Remember, with flu, even if you don't do a flu vaccine, if you get flu, there are some demonstrated antivirals that are available and that work. We don't have that for COVID. We have a couple of things that we are investigating. The hydrochloroquine, I think that's it, hydrochloroquine, turns out probably not to work for most people, but we have a couple of others that are showing promise. But we are literally building the airplane as we are flying it right now because our healthcare systems are completely overwhelmed and we are trying to figure out new treatment options at the same time as trying to keep people alive. Part of what contributes to the mortality rate for COVID is that if people get very, very sick, they require an enormous amount of hospital-based resources, and those resources are decreasingly available to them. So when we talk about flattening the curve, it's really mostly about the gap between the number of people who will get infected and sick, and the number and the ability of our healthcare system to keep up with those needs. Everybody who falls between those lines of hospital capacity and the peak of infection rate, everybody who falls in between this line is unlikely to get the medical help that they need. And so, that's a big part of what makes this so deadly. If we can slow down, if we can flatten the curve even without developing a vaccine, and that's a rabbit hole we can go down only if you want to, but if we manage to flatten the curve, the same number of people will be exposed to the virus, but will happen over a longer period of time, and so our healthcare systems are not so very, very overwhelmed. And we may have time in the meantime to develop some treatment options that are more effective than what we have right now. So, I hear over and over again, less these days, but but a week or two ago was hearing over and over again about how flu in the United States kills anywhere from 30 to 60,000 people a year. And so why are we losing our mind over this? Well, COVID has killed 40,000 people in the last 5 weeks. We don't see refrigerated trucks to be temporary morgues on the streets with flu. We don't see cities turning on their ice rinks in case they need temporary storage space for dead bodies with flu. And we're seeing it with COVID. And so for people who are wanting to believe that this is not a big deal, I ask them, I beg them to be aware that it is a great big deal. It is a bigger issue in some places than others. I have the tremendous privilege of living in a tiny little town where people are taking it reasonably seriously. So when I go to the grocery store, most people are wearing a mask, people are keeping their distance. But I also have I live across the street from a beach. I can go walk, I can maintain social distance for 5 miles, not seeing anybody, in my neighborhood. And that is not true in urban centers where the virus has really, really taken a hold. And I'm eager to hear about Diana's experience with this because, of course, Diana's in Seattle, which was on the leading edge. And I mean, it's just so interesting to look back on this because at the end of February of this year, Diana and I both spoke at the same meeting in Seattle. And we were just getting reports. As it happens, I was doing a class on public health issues, that herpes, hep, and flu one that you mentioned earlier. And I always leave space in that for what's new, right? And so I had a little section on Zika when that was the thing. So I had a little section on COVID when that was the thing. At that time, there was one case in Edmonds that we knew about, and that was all we knew. That was not that long ago,
No.
right? The last week of February. Or maybe it was the first week of February. In any case, it was not that long ago. And here we are in the United States. We'll hit 750,000 diagnoses today. And again, remember, that's artificially low. And we crossed 40,000 deaths yesterday. And that is, that's a tragedy. It makes me sad. It makes me angry. It makes me worried. I want to emphasize that while people who are older and who have underlying health conditions are most at risk, in the United States, about somewhere between a third to a half of the people who are in the hospital are under age 60 and who may or may not have underlying conditions. So the fact, if you're young and healthy, that's awesome. Stay that way, stay healthy, but also keep the people that you love healthy by not not exposing them to unnecessary risk.
Yeah.
So yeah, COVID is different from flu. That was a little bit of a long-winded description of that, but yes.
Yeah, but that was really helpful, and I think it's really important, really important to state that. And in answer to your question, I'm in Alberta, Canada, and we happen to have the highest test rate in the country, and so our numbers are becoming more accurate. But we're still seeing almost 200 a day just in Alberta that are getting it, but because we're testing more as well now, and they're doing like the drive-through testing, and so we're really, really fortunate. But I happen to have a niece who is an emergency room nurse in Kamloops, so that's a small town in British Columbia. And when we were texting and talking the other day, she said she's seeing people under 50, people in their 40s who, like you said, they're getting sick, no underlying health conditions. And where as a new nurse to the profession, she would not have intubated people, probably maybe for many years to come. And now she's doing it, on a regular basis. So it is, as you said, it's a really big deal. So Diana, what are you seeing in Seattle?
Well, it's been really interesting because, and I first want to say my internet connection has gone in and out a couple of times, so I've lost you guys, and then you came back. So I don't know if I'll do that to you,
Okay.
But being in an
so
urban area, everybody's online,
Everybody's
probably
on the
doing
internet.
school right now. because we live right by the campus. So um, we did get it really, really early. We had the first event in February, and we were lucky because the Gates Foundation was doing a flu project. And so everyone, let me just see here because I don't hear you through my speaker anymore. Okay. Anyone who had flu symptoms could send an email and they would get contacted and get a flu kit and get tested. And they were identifying COVID at that time. And the CDC shut them down because there's always that potential, but it's not accurate because it's being done by scientists and not by medical professionals. Anyway, I'll try and keep my opinion out of it. But so they were able to get the fellow in Edmonds, the person in Kirkland, and then a high school student who was on his way to school, and they stopped him at the front door and told him that he had tested positive for COVID. And he was the first one in the Seattle area that had no direct exposure. It was a community-based, he had no idea where he got it. And that was in February. So we were alerted really early on, and having the first death in the country was very much a wake-up call. Because I kept thinking, well, are we ever going to get it? Because in January, my wife works for the county, and starting in December, everyone at the county went on alert for an emergency. So that every time a flight came in from China in January, all of the people, all of the passengers were tested, and their temperature was taken, and they were isolated in hotel rooms, and the governor was buying hotels early on. So that's been great for us. However, the scary thing is, we think as of late February, we're all taking extra precautions on disinfecting everything, washing our hands. I had hand sanitizer out in my room. I was showing everyone the CDC version of, and then I learned the WHO version, which was even more regimented than the CDC version. And so I was showing all my clients that, and we were both doing them before they even got on my table. And a friend of a friend of mine, so a little distant, her very last client that she saw mid-March had it and didn't know. It was completely asymptomatic, and within 2 weeks they were both in the hospital.
Oh my.
So she decides to shut down. She thinks for 3 weeks now she's been doing everything right, and I don't know how she is today, but as of a week ago, they had both been in the hospital for at least a week at that point. So I think what I worry about most are, as essential healthcare providers in Washington, that we have this inflated sense of ourselves, or that we have this urgency driven by finances. When you're self-employed, it's just been difficult to survive at a certain level. I'm lucky that I have a wife who's still working. I think a lot of people don't. I also have that burden of having another healthcare issue as a type 1 diabetic. So it's been really easy for me to say, no, I am not working. And more than half of my clientele are over 60 and are fragile, because I see a lot of pre and post-surgical patients. And and many of them have more than one comorbidity. So it's been easy for me to make that decision, very difficult for other people to make that decision. And I think we're under this false assumption that if we disinfect everything, we're going to be safe. And it's just not true. There is nothing that can protect you, really, as we watch our healthcare providers fall and our bus drivers die. We had a bus driver die last week. So I'm still in that place of, I wish no massage therapist was working, because we can be such petri dishes for our clients.
Mhm.
Yeah, and that's, yeah, you make a good point, because in Alberta, they shut us down. So that was a huge piece, to actually be told, you can no longer practice. And I know in Seattle, they have not done that with you. So that, you know, and you're trying to advocate for your profession and take care of your professionals. So let's dive into the conversation then about what are some of the things that we should start to prepare for. Like, what's the difference between cleaning and disinfecting and sanitizing and you know, all of a sudden, yeah, Ruth. Okay, Ruth is going to dive in on that one.
I just want to say how much I really appreciated what you just said, Diana, because there's so much tension between A, I'm out of money, and B, my work could really help right now. I mean, when have we ever needed massage more than we need it right now, right?
Right.
And on the other side of that tension is, how can I be safe? And a big part of that conversation is around personal protective equipment. And I really think that if access to personal protective equipment for first responders and people on the front line of this had not been so compromised, this whole thing might have worked out really differently for massage therapists, because I could see maybe in certain, especially in hospital settings, massage therapists who are fully gowned and gloved and masked being able to offer massage to people who really, really need it, in the same way that they receive nursing care from people who, you know, for people who really, really need it. I can make an argument for that, but I cannot make an argument for massage therapists taking equipment away from doctors and nurses and paramedics. And I have a buy-in on that. That's my bias, because my son is a paramedic. He is on the front line, and he didn't get an N95 mask until 2 weeks ago. And
Wow.
yeah. And so it's unconscionable to me to think about massage therapists taking personal protective devices or equipment when other people who are much more at risk need it more than we do. The other half of that, as I've seen, and this might be a geographical thing, is, as you know, when we go to the grocery store and there's I posted on Facebook, I went to my grocery store, they had no beans, no rice, no flour, but there was a whole shelf full of ghee and rendered duck fat, right? So the things you can buy are a little peculiar. And so we go to the grocery store and we're looking for staples, but you know what else is becoming hard to come by is really good cleaning product. And so, you know, partly in answer to your question then, to circle back to your question, Melanie, cleaning and sanitation mean essentially the same thing, which is taking efforts to remove dirt and contaminants from an area. Disinfection has a specific meaning, which is to kill and remove as many pathogenic items, as many pathogens as possible. Typical disinfectants work against viruses, fungi, most bacteria. There are classes of bacteria that have the waxy spore around them, like tetanus and tuberculosis and anthrax, that most disinfectants won't work on. And so then you need to go, the next level up is sterilization. And disinfectants come at different levels of effectiveness, or different levels of severity is not the word I'm looking for, but I think you know what I mean. Different levels of
effectiveness. It makes sense.
Effectiveness. Let's go with that.
Yeah.
Yeah. as it happens, COVID is not particularly resistant to its environment, right? It dissolves with soap and warm water. It doesn't take extra bleach in the laundry. It doesn't take super high temperatures. It just needs regular, wash your laundry with soap on high, dry it on high heat. So far as we know, at this moment, COVID will not withstand that. Disinfecting surfaces, there's a list of approved disinfectants specifically for COVID that of course covers a multitude of many other things. If you like, Melanie, I can get you a link to that list and
Perfect.
you can, offer it up with
Yes.
these show notes. I think when the time comes, please don't ask me when that is, that we can think about opening our practices again. We need to be sure, and I love Diana's idea about demonstrating how we do this. We need to be sure that we are using disinfectants that have been demonstrated to be effective for the pathogens that we want to target. So I had a question early in an interview earlier today about diffusing thieves oil in the air, and wouldn't that be an effective disinfectant? And A, I'm not your go-to resource on essential oils, and B, the research that I've seen on essential oils has not been in vivo, in living people. It's been throw this at a petri dish and see if it kills the thing.
Right.
And those are two really different things, right? And C, please don't use something on the hopes that it's effective. Please get some data. Think about people with compromised lungs and then diffusing something strong enough to kill pathogens in the air. What is it? There are some logical things there that are hard for me to follow. And don't at me on that. I'm not an essential oils
Right.
expert.
Yeah. But that makes sense about putting what you're going to add to the air.
Yeah. Right. Yeah. So in our new normal, and I wrote this in an article that was published not long ago, I think we need to consider that our days of the 10-minute turnover are over. And that we need to anticipate swabbing anything our clients touch every single time. That's doorknobs and switch plate, the light switches and what they might touch in the bathroom and the credit card machine or, whatever other devices we have. And that also goes to us and our computer keyboards and our mouses and our phones and all the things that we touch between every client. And so doing that in the 10-minute turnover may not be practical. The other thing we need to think about is not having crowded waiting rooms. Right? Because when we ask people to wait in the same area and touch the same magazines and breathe the same air, which may or may not be well ventilated, we are putting people at risk. I've had suggestions from people to look into good quality air filters. And I think that's something to think about when, especially, some massage therapists are working in big airy rooms and there's good air turnover. And so if someone sneezes and they're 8 feet away, you probably are not in the path, right? And other people are working in very small rooms that are stuffy and warm and close. And then someone sneezes and it's in your face. And what do we do with that? So the data on COVID being airborne versus being droplet-borne continues to develop. It's sort of weighing in the direction of droplet-borne. There was a new study on that I just ran across today that tracked infections in a restaurant. Someone went in who was positive but asymptomatic in a restaurant, and everybody in the line of the air conditioner vent with this guy, not everybody, but 90% of the people in the line showed signs of contact. Yeah, right, but not in the rest of the room. So that suggests droplet rather than airborne.
Gotcha.
But, these are things, you can't base policy off of one study, but it's a pretty interesting observation. So as we envision our new practice, we need to think about scheduling so that we have more turnover time. The obvious, and I use the word theatrical carefully because it's theater to demonstrate the way we are taking care of ourselves and our clients, right? And the policies that we set around that. It's investing in the right equipment in terms of disinfectants. I am a strong component of changing our top for every client, whether that's an apron or a shirt. If you can't afford 6 work shirts to get through your day, you're not ready to get back to work. These are baseline things, and thinking about air quality as well. These are some super baseline things. The trickier things that I think we're going to need to think about is how we're going to change our intake forms, and that's Diana's department.
Yes.
But also how we're going to set policy around who we see and who we deny.
Yeah.
Right? Because I would love to say, you don't work unless you know your infection status. Here's the problem with that. The current tests have a 25 to 30% false negative rate. And antibody tests are not gonna save us. And there are new indications just developed over the weekend. And I hate that this is true, but you can't pretend it's not true because it's inconvenient. One exposure may not impart immunity, at least for some people. And that is very, very important for us to know. So in the world of infectious disease and massage in the past, when we've looked at, we all 3 of us are old enough to remember what it was like when we were making decisions about if we were going to take clients who were HIV positive. Right? And there was a lot of fear and a lot of upset and a lot of hair pulling about that. When it was possible to demonstrate that HIV is not communicable through casual contact, then it was clear that to deny those patients was illegal discrimination. COVID-19 is a very, very different thing. We are allowed to say to people with flu symptoms, no, it's not safe for me to work with you today. But COVID can be silent and communicable while it is silent. And so what do we do with that information? So one of the things I'm asking for from our organizations cannot tell us what we're allowed to do. They can't. They can give guidance. They can give suggestions. What I have asked them to do is a couple of things. I've asked one of our organizations to think about making their attorneys available to help people work with their policy setting and with their intake forms so that we're sure that we are legislatively correct. And I've asked them, and I don't know that this is a practical suggestion, to reach out to our policy setting governmental agencies, specifically the CDC and the OSHA, Occupational Safety Health Administration, who set standards about things like laundry temperature and surface disinfectants, to see if we can't carve out some real estate there specifically for manual therapists like massage therapists and their guidance there.
Yeah, that's where I think we're going to see it as well, is coming from government. Because, and especially in a regulated environment, that's under the Health Professions Act. And so there will be, I think, directive, and because we were shut down by our health profession in Alberta. So I'm going to appreciate that. And I hope that we have some ability to have input into that as well as professionals, like you said, and Diana, like we need to obviously ensure that our clients are safe, but we need to ensure that we're safe.
We also are safe.
Yeah.
And there's a whole thing about, are we going to hold harmless? If our clients lie to us now about whether they're sick or not, how many times have you had a client who's coming in and they're all, it's okay, it's just allergies.
Yeah.
Right? And then 2 days later you have their cold.
Yeah.
If that happens now, we could be dead, or we could be disabled, or it's really, the stakes are so much higher.
Even higher if you think about how many people you could then infect.
Yes.
Right, exactly. Exactly. So it is fraught. And the thing about getting the government involved, which I think is good because it's nice to have a single authority that says, okay, yes, it's safe, is that it has to be evidence informed, and your
Yes.
government has to know something about massage. Diana and I both have governors that have been really great about creating some restrictions in our states. I love my governor, and I love Jay Inslee too, but they have this blind spot about essential services. And consequently, any massage therapist who calls themselves essential could conceivably continue to practice. And it's not okay.
Yeah.
If the government's going to make decisions about our ability to practice, they better understand what we're actually doing.
Right.
Yes.
Yeah, and that creates a whole other layer of confusion too. So,
Yes.
Diana, what are you starting to think about for your practice when people are, when you're thinking about reopening? And again, because you disclosed that you have type 1 diabetes, so you are already at a higher risk. And then you deal with a population that is at a little bit higher risk as well.
Yeah, I have a couple of things. First, one, I really appreciate Ruth. I was able to tick a few things off my list, so way to go. And two, I wonder about checking for fevers. Like that seems to be a practice. Is that something that we should do, whether or not we can do it, Ruth?
I have opinions.
Yeah, I do want to know.
Yeah, I have an opinion. It's not a particularly clear one. So I think the first question is whether checking for fever is within our scope of practice. And that would be something to check on. But I think doing like a forehead strip rather than something you have to put in somebody's mouth, right? Doing a forehead strip, if you have mutual agreement, if you have informed consent, it's probably fine. You can set policy that anyone whose temperature is above a certain level gets deferred. And then you have to apply it the same to everybody. Countries that did early management of COVID relatively well, although they're seeing now the secondary spikes, part of what they did is they took people's temperature when they got off airplanes and when they entered public buildings. And if they came up positive, they got tested. And if they came up positive for that, they did contact tracing. And, we can take a temperature and we can send someone home if they have a fever, and, encourage them to self-isolate, but that's as far as we can take it. I think it's fine. I think it's better than nothing. It certainly is not adequate.
Yeah, and what I've noticed is it's really impossible to find a thermometer these days. I mean, I've looked, I have an ear thermometer and I can't even find the covers for the tip to keep testing myself. So, and luckily, there's the two of us and we've isolated together. So I'm not so worried, but still that's an issue if you're going to test your clients, certainly.
Yeah, and that definitely goes into that ethical piece, and I'm sure you're going to talk about that too, Diana. It's just like, what can we ask them? What can't we ask them? What can we disclose? What can they ask us? Those kinds of things we get into, like even a deeper dive of like, okay, Diana, you're coming in. Once there's a vaccine, have you got that vaccine? Have you traveled? Has anybody, like that list of questions that we're going to ask and allow them to
answer. And as far as I'm concerned, because I am consumed by this, all bets are off, really, in terms of what we can do. I am much more concerned with the ethical perspectives of this. This is what we should do, regardless. It was kind of one article that I read about the Gates Foundation is, really they were up against the CDC telling them to stop and their ethical, hardcore ethics telling them you've got to keep going with this. So they did for another, 3 weeks before they got completely shut down, because they were able to identify people with it. And then they got tested by the CDC. And yes, there was some confirmation there. So at least they were identifying people that likely had it. So I also want to talk about PPE. I totally appreciate what you said, Ruth, about that. And if we can have access to PPE, and I would say enforce every client to wear a mask. And if they're not willing to wear a mask, they don't get a massage. And you wear a mask, and it has to be changed between every client.
Absolutely.
And what I just read out of the CDC this morning is that
That's
bandanas are not acceptable.
Mhm.
Bandanas are not acceptable. So you have to have something that really covers and fits snugly and is 3 layers thick and has a barrier in there. Anything from, gosh, I've heard everything from the wipes at the gas station, those blue cleaning wipes. They work really well as filters to put in between the layers, as do coffee filters. They don't hold up as long as the blue things, but the coffee filters will last for a few washes as well. So you want something you can slip in there and actually replace
right.
every time, and so you're not washing it with that in there, the filter. And how you take off your gloves, mask, and shirt are as important as putting them on. So you'll want to take things off in a way that you can get everything
That
off and
contains, yeah.
inverted, and then take your gloves off. But again, you don't do any of that until you've wiped down everything. And then you end up in the bathroom where you can take everything off, put it in plastic, and wash yourself completely. And then go out and don your next set of apparel. So let me just check my list.
Yeah, so that means not just what we have to do, but also the process.
There's a skill.
Yeah, of what we have to do, and just even the, when I just sort of have a thought of walking through with my clients what that looks like when they come, and I practice at home, so I'm lucky. I have so much control over my environment. I'm really, really fortunate. So I know the when they come in, they might use the bathroom, they go into the massage room, everything is right at my front door, and the first 2 rooms in my house. But every single thing in my massage room that gets touched. So now starting to take out any little thing that just is an extra little tchotchke, or a little frame with something on it, or my essential oils are usually out for my clients to pick from. So that will all have to be behind glass, and so they're just running through that whole process of every single thing that we touch, that our clients touch, all of those different pieces of the puzzle. Okay there, Ruth? That we're going to have to pay attention to. And then the process of, now I'm the cleaning process, what that looks like, how I ensure that every little piece of my room has been sterilized and sanitized, and maybe sterilized isn't the right word, but sanitized. And then, like you say, Ruth, you were talking about like your computer. So you come back to, your file that you have for your client, new client files with paper and pens. And so we are really going to have, like, for me, that's a checklist. Like, I need a checklist. And I love the idea of doing a checklist where I can literally check off all of the things that I've done. And I can demonstrate that to my client, that I've checked off all of these things. And so to help demonstrate that for them, and obviously, and we'll get into this with you, Diana, like, what do we need to change with our intake forms, our charting, and then communicating in advance with our clients what they need to do when they come in as well, what our expectations are of them.
Yeah, I want to piggyback off of that and just say, we also don't want any furniture that's cloth. So if your waiting room chairs are cloth, take them out. You want a solid surface. Wood is perfect because you can wipe down wood. Leather, you can wipe down leather. And make sure you've got those hospital grade wipes. I buy a case like maybe every 6 months,
Right.
and wipe down everything in between. If you've got any sort of, certainly I'm hoping no one does this anymore, but I have heard people that layer sheets. I actually got a massage once where people layer
Oh, we've lost your audio. We've lost your audio. We've lost your audio. Yep, lost your audio. Not yet, no. Just gonna pause. Oh, there you
there
go.
we go.
Yeah.
Crap bullet. It's that darn internet.
Yeah, your video is going in and out a little bit in your audio, but
Yeah.
you're back.
Okay, good. I
Yeah.
swear it's kids at school. I think
Yeah.
they're going to
Oh.
go on a lunch break any second now.
There you
So
go. I
go
think
to
we're gonna
lunch,
just break the
guys.
internet anyways with, you know.
Yeah, right?
Yeah.
So no cloth furniture,
Right.
no layering sheets, no fuzzy, lamb wool, whatever, covers on your tables, no heating pads unless they're covered with a vinyl
Right.
covering. And a lot of table covers, a lot of table companies have table covers that neatly tuck and fit exactly, and you can put your table warmer under that. But nothing in your office that can't be wiped down with a disinfectant wipe. That's an antibacterial and antiviral wipe.
Great. Those are really good tips. So that's probably the first thing that we can do is just go do an audit of our massage room.
Yes.
Start with that. Just take anything out, like you were talking about, anything extra, anything that's cloth, and starting to order those protective covers for anything that we're using, for the blanket that we're using, for the
Yes.
lamb
The
wool that's on the
pillows.
table, for our pillows, our bolsters, we're gonna have to really again step that up. So this is the perfect time to do that audit and to start getting prepared for that.
And no swiping of credit cards anymore. If you can have online payments, even just get a PayPal account or something where people can pay online before they come in. Use an EHR, an electronic health keeping system that's online so that no one touches any paper or pens in your office. Really, none. Everything should be done electronically or done without them. And I do know of one where clients can log in and fill out everything online, all their pre-session information as well as their intake forms, so that they can communicate with you online within the system, and you can get all your subjective data online before they even come in. And that's by far the safest way. And really it's much less of a plug than it is a necessity. Any system that does that, I would completely support you using. It's just critical right now not to have pens and papers in your office.
Yeah. So let's go down that path, Diana, because that is your area of expertise, is that intake form and that charting, and you've designed your software program to incorporate all of that. So what do you think it's going to look like as far as updating our intake forms and updating our charting skills? Like what are some of the things that we're going to need to add to our charting?
I think it's really important to have an additional intake during this time. I don't know that you necessarily need to change the one that you have, but add another page to it. And it should ask all kinds of COVID related questions that we don't even have in here. So I found a really great article in JAMA, the Journal of the American Medical Association article that came out just on Friday. And it talks about primary symptoms and secondary symptoms as one route to take for an intake. And then we need to talk about exposure and types of isolation that people do or have been doing, so that we get a sense of how careful have they been about their exposure. And of course, all of that depends on, are we at the point where we can identify what somebody's status is? I like a lot what you said, Ruth, about that. We really need to know people's infection status as well as our own. I think the most important easy ones are fever, cough, shortness of breath, sore throat. Those are the really primary out there ones.
Anosmia.
That anosmia. I heard of coryza.
Coryza. That's a
Coryza.
cold, right?
I know, right? But now that's a secondary symptom as of Friday.
Oh, okay. Yeah, but
that one I
anosmia
don't
is
know.
being well accepted.
Oh.
Right. Loss of the ability to smell, or loss of smelling sensitivity.
Right.
Yeah, you must have done really well on your SAT scores. Very nice. That's a good one. Okay. So secondarily, the first one on the list is myalgia, which is really just sore muscles, right?
Yeah, just soreness, body aches, right?
Right. And I mean, isn't that why people are coming to us anyway? So
Yeah.
that's a tough one. So then you've got to really distinguish that between everything else. Like, is this something in the recent future, in the recent past? Is it different than it's been in terms of something really
Right,
site
that's the thing.
specific?
Especially if it shows up with a fever.
Right. Then it's a slam dunk. But, you've got to ask some really probing questions. You might have an intake form that asks about pain and soreness, but, you've got to probe a lot further than that. So myalgia, chills, loss of taste and smell, we've heard about in the recent weeks. But actually the stuffy nose, the inflammation of the nasal cavities is up there on the list now, which, for a long time, I think I was at least codifying myself by saying, well, if they've got a stuffy nose, then we know it's allergies, but that's not the case anymore. So, and the other one is fatigue, which, really, since we're all kind of isolated and a little depressed, I don't know about you, but I'm like, I can't get as much done during the day.
Oh yeah, focus is for nothing.
Right?
Yeah.
Exactly. Crap. So those are the major health-related questions that I think we have to ask. I think we also have to ask about exposure to other people.
I was going to say, people are asking me or showing me prospective new intake forms and asking questions about travel. And I'm recommending that they add something about exposure and recent visits to nursing homes. Right. Nursing homes and long-term care facilities, because it's a completely underreported hotspot.
Right. Well, actually, you bring up a good point too, Ruth. So, it triggered something in me that we might also have to suggest or learn what a person's activities are normally. So if normally you go for your massage and then you go see your mom in the nursing home, maybe you have your massage at a different time when you have 4 days or 5 days in between going to see mom in the nursing home. Like, that's going to have to be part of the discussion too, is what is your daily activity like, just in case.
Yeah.
I happen to be, part of a transmission, system that I wasn't even aware of. And now I find out, yeah, that my client normally goes to see her mom right after. So
Right.
that might be something, I don't know where that lives in an intake form, in a general, we start to have to ask deeper questions about, normal lifestyle practices or lifestyle.
Right. Yeah,
It's
good
it's sort of a
thinking.
high risk activity, isn't it?
Yes.
It is. It is. And it's very unfortunate that we haven't been tracking it like we should be as a country. And I wish that we would, having a mother-in-law in assisted living. So
Right.
I think it's also, what kind of precautions have they been taking over this whole time? What type of isolation did they do? When they went out, how did they protect themselves, so that we really know how well people have been taking care of themselves, as well as how seriously they're taking this condition. So I think that makes a big difference as well. So those are the kinds of things that I've thought of so far. You guys are also giving me some great ideas here. But what I'd like to do is come up with a really comprehensive list and make it available. I'm certainly going to put it online in my EHR, and I would love to make it available widespread.
That would be
I
awesome.
think, yeah, I think you've got a really good idea too, just for a checklist, Melanie, for how you're cleaning your space between clients, that you really want to make sure you're hitting all the primary things and that you don't miss anything on your way through your office in preparation for the next client. I have always had to be in a place with either one level or an elevator. And so sterilizing the elevator between every single visit. I'm in a multi-floor building right now, and sterilizing even the doorknobs on every door along the way. And luckily, the space I'm moving into when I go back, I have the luck of one lease running out and the next one not starting yet.
Wow.
They're willing to hold off on charging me for the new space until we legally can go back to work. So, which is also that kind of sketchy place, like, is your governor willing to understand what massage therapists are going through in making that decision?
That's a conversation that has come up several times, as well as, people ask, well, will my malpractice insurance cover me? And I think if it is technically legal for massage therapy to be taking place, then insurance companies have to step up or write some new policy about if a client wants to say they caught or transmitted an infection because of your malpractice. And we may need to think about our own health insurance or our own work insurance about our exposure to people as well.
Right.
Lost you.
Oh, we've lost Diana. We've lost your voice again. Those kids are submitting their exams in high school. So I'll continue on that until we get Diana back, because she looks like she's frozen. And
there she is.
Oh, okay. I know with our association in the Natural Health Practitioners of Canada, they're already starting to work with our liability insurance company to talk about what we can have covered. And I know, because like a lot of our clients have secondary healthcare coverage where massage is covered, because we were shut down, that also got shut down. So even if someone decided that they wanted to practice on the side, insurance isn't going to recognize that. So there's, this has more layers than, I mean, here's just the three of us talking. And I know we have been talking to other people, and we have been, getting inquiries ourselves about things, but there are so many layers to this. And I love that we're starting to open them up and uncover them and start to talk about them and starting to design and develop things. And that will continue to be developed. And, you know, leading into sort of the research piece, I do want to finish though, Diana, with just talking about charting though after and changes we might have to incorporate. But in the research piece, now we're starting to see the research coming out of China and other countries that have had it for longer than us. So that'll be the other layer too, that we can start to take advantage of research that's coming out. So let's jump back into charting and then jump into research.
Yeah, I think in terms of our daily documentation outside of the intake forms and inside the treatment rooms, we just want to be really clear about what PPE we're wearing at the time and what precautions we took. I think that's really important to chart.
To document that for sure. Great idea.
Daily session note. I think it's also really important to chart any type of symptoms that you're finding. There's a lot of things I think we don't necessarily mention, but if it's anything that's on that primary, secondary list for COVID, we want to make sure that we're documenting that, even if there's another explanation. So that we at least can say, you know, we asked about this. It really, you know, the findings showed that there's another possibility to explain this. So I kept working so that you can really sort of substantiate your decision-making process for the treatment session itself. And it will also help the client feel better. I think anything that's questionable, you ask more about. You don't ever shy away from asking questions and documenting the responses. So the more you chart, the better. The other thing that's really nice about some electronic charts is you can use your microphone on your device and just talk into it so that you're not having to use your keyboard as often, because anytime you touch anything outside of the client, you've got to disinfect your hands again. So keep the hand sanitizer available in your room. Some of you might have a sink in your room and you can keep washing your hands. Obviously, washing your hands is your first choice. Sanitizing
for sure
with a hand sanitizer is your second choice. So, but just be really thorough with your intake process and thorough with your documentation process in the session. And I wouldn't want to forget anything. So don't be afraid to stop and chart something, just sanitizing afterwards. But at least at that time, you've just got the two of you on your hands, whether they're gloved or not. That's a whole nother conversation. I, of course, have donated all of my unopened boxes of gloves and just kept the open box. So at some point, we're going to also come up against that inability to have access to gloves and need to decide how we're going to go about this. And that'll be an easier decision to make when we've got widespread testing available.
A little further down the road.
That was me knocking on wood.
Yeah. Thanks.
Wow. So it sounds like there's some things that we can do now, and we can start to do now, and we can start to think about now in the intake forms. And it sounds like we've got a lot of really great, smart, wonderful people who are already on top of this in, you know, in a lot of our organizations and within our profession, that we're already starting to have the conversation and share the information. So I think we're really going to see that starting to come out. And I do just want to touch on research just before we finish up, because of course that's, you know, both of you again, we're part of the Research Foundation and still are. Oh, did we lose Diana there?
No, I don't think so.
I think I'm back now.
Oh, okay. I just wanted to touch on the research piece and just to, you know, is there anything coming out right now? And then of course, where should we go for our sources? Like, you know, where can we find the actual, the research that's coming out, the truth in the research that's coming out. Looking for the truth here.
I missed all of the last couple minutes, but
Okay.
I can hear you now.
I've got a starter for this.
Great.
So the question, Diana, is, where do we go for good information? And that's a really, really hard question, and I wish it shouldn't be. It shouldn't be a hard question, and it is, and that has to do with politics. And I wish it weren't the case because it's infuriating. A starting place that I love in terms of, let's think about, how can we do a Diana and find something really good in all of this, because that's one of my favorite things that Diana does, is find something good. This is a great time to start building our information literacy. In other words, our ability to discern what's trustworthy and what's not trustworthy from what we're reading. And the ABMP published an completely online, open to everybody, there's no print versions of this, issue for massage therapists, and every article in it is around COVID-19. And the cover piece for that was written by Sasha Chetow on how do we figure out what's true. And I have never read a more useful way of thinking about critical thinking and how do we make sense of what's being thrown at us in a constant way. This is a very, very, so that's my first thing, is start there.
Great, and I'll put a link in the notes.
Yeah, that'd be great.
Video.
Great.
Really, that was an outstanding piece of work that she did, and they built the whole issue, around that article. I like Johns Hopkins University. I like JAMA, the Journal of American Massage. Oh, sorry, Journal of American Medical Association. I get frustrated with the Centers for Disease Control because they're always about 4 days behind. And because they have to publish things that suit messaging that is not always science-based. And that is extremely frustrating to me. So at this point, I would recommend going with academic resources rather than governmental ones. And it breaks my heart to have to say that, but that just is. I trust Dr. Fauci. So I think when he says a thing, that's something that's usually got some good grounding behind it. And for our listeners who aren't familiar, Dr. Fauci is the head of the National Institutes of Health Division of Allergies and Infectious Diseases. He has a long, long history in this field, and he really is our leading spokesperson on infectious diseases right now, and good policies around that. Yeah, it is. Oh, and the other thing I'll say is, because this is such a scary time, and because people are eager for any rationale to get back to work, conspiracy theories about viruses have very rich ground to grow in. And I get them sent to me every day, every single freaking day. And so I know that Bill Gates manufactured the virus so that he could manufacture the vaccine and make another gazillion dollars. And I know that vaccines don't work, and the way to fight the virus is with vitamin D. And I know that, oh my God, it goes on and on and on. I got the thing with the blow dryer. Did you guys see the thing with the blow dryer in the face?
No.
Oh yeah, because the virus doesn't tolerate high temperatures, so you spray cold water up your nose and in your mouth, and then you heat it up with the blow dryer, and that will kill all of the virus in your respiratory tract.
Wow.
People send me this stuff.
Very, way on the outside there.
Oh my God. So
I'm so glad you get it.
Thanks.
Yeah, it's prevalent. It's prevalent.
It is, and I get where it's coming from, right? It's coming out of, I have to get back to work. I need a reason to make it okay to get back to work. And I need someone with a position of authority to tell me it's okay to get back to work. I get a lot of that. And so I just want our listeners to be really, really critical thinkers and to ask, what's the rationale behind this way of thinking? They don't pull out freezer trucks for the flu. So this is a virus that is completely different. And people who are selling a quick fix or selling a simple answer to a complex problem do not have your best wishes as their primary interest. They're, they
Yeah. Yep.
the thing about following the science that another thing that makes following the science really frustrating and harder to do than following quick answers is that science changes the answers all the time. They keep changing their minds. Is it, can you get immune or can you not get immune? Will the antibody test work? Will it not work? Will the nasal swabs, are they accurate or are they not accurate? It changes. Science that doesn't change is less trustworthy, I'm telling you, because the purpose of scientists is to continue to develop information.
Yes.
And you
I
start
wish it
with
were
what already
easier.
exists. Yeah. You stand on the shoulders of the other scientists so that you can keep
Adding
developing, and saying, is that really true? Is it true in every circumstance? So that when they make a big statement, when they're influencing policy and the government, it comes from a really solid base.
Yeah.
So it's important that they argue with each other.
Yes. Yeah. And we know that this is, again, this is the beginning. This is the beginning of us even thinking about going back. We don't know when that's going to be. And that is going to develop. And it could, it's going to develop as much as new information will come back. Even when we get back to work, we need to be, nimble on our feet, and we need to be quick to respond, and we need to be quick to add something new and to adapt and to continue really, really great communication with our clients. And really managing our own ourselves, protecting ourselves, protecting our clients, protecting our families. So I think there's a lot of opportunity in that of learning. What does research look like? How adaptable can I be, and create great communication skills.
I'll add to that adaptability, Melanie, that we need to be ready to, if it becomes safe, whatever that means, to open up, we need to be ready to close down again.
Right.
The Prime Minister of New Zealand, as of today, lowered the alert level from a level 4 to a level 3 for 2 weeks, and then reevaluate. And I thought that was brilliant.
Yeah.
Yeah.
Good.
You had something to add too, right?
Yeah. I also, sometimes reading original research is really hard for some people. So I wanted to give you some more chatty, I use that word.
Friendly.
More friendly summaries of research that that way it takes 1 or 2 or 3 studies and kind of makes a more global summary about it, but still is not in that place of this will never change, like Ruth said. But Science Daily is a good one that you can sign up for just as a email alert.
I have it on my other screen right here.
Oh yeah. Yeah. It's by far my favorite. Another one that I rely a little less on, but comes out more and actually has more relevant information, but I take it with a grain of salt, is Medscape. I think Medscape is a good one. It feeds information to the WebMD site, which, feels to me like the Wikipedia of healthcare.
But Medscape is hardcore, and it's not, I wouldn't ever call it friendly, but it is relevant.
Yeah, it's super relevant. And I do think of it as friendly just because it's a summary again.
Right.
of a study, and you're not slogging through the whole study to get to, you don't want to ever just read the abstract. You always want to read, the introduction and the conclusions. So I always read those two first and then go through and see the methods and blah, blah, blah. But you can learn how to read research. This might be a good time to do that for you. I also get it that a lot of you are homeschooling your kids right now. And that makes things really difficult. And those of us that don't have kids or don't have kids at home, we're probably cooking a lot more. So I know, it's crazy. I'm trying bread today. I'm going to do it. But
homemade cream puffs, baby.
Right? Oh my God, really?
I've been watching way too much Great British Baking Show.
Oh, then please send me the recipe if you find
okay.
a good one on that. Okay. So those are email alerts that you can get and just peruse every day. And so I open probably at least 5 to 10 a day and just take a quick scan of them. And sometimes it's not relevant and I can toss it. Usually I flag it and never go back to it, or I actually download it and put it in a folder.
Cool.
I do look at OSHA and the CDC, but again, with that caveat of it's several days old. So always the first line research is what you want to read just to know what's coming up. And then I kind of look, like the last thing I looked at in OSHA said, anyone working within 6 feet of potentially exposed people must wear PPE. Must. So that's an OSHA standard. Anyone who is working for an employer, anyone who is an employer should be following that, period. So hands down. I look at WHO a lot. And honestly, I read the New York Times because on Tuesdays, they've got their science section. And that's a really great section to see what's going on. But a lot of sites are doing COVID updates on a daily basis.
Yeah.
The other thing I really look at on a daily basis is Politico, because I want to see what's happening in the government. I'm the co-chair of the Government Relations Committee for AMTA Washington. And Susan Sherman is my co-chair. And so we've had direct access with the Department of Health in Washington. We've been able to communicate about massage therapy. We've got a very responsive director in there. And we're able to get messages to the governor. And we've been able to refine that essential care status, what that actually means. So the last refinement said anybody that's in an acute phase of a particular injury, but I really much prefer the standards that are put out, and I saw this one on Medscape, what doctors are discussing in terms of essential care. So if a doctor is trying to define whether a surgery is essential or not, and we're thinking that massage might be essential, I think we really need to look at what doctors are faced with to make those kinds of decisions. And they are equally as up against, do we use PPE when it could be better
resources.
used? Yeah. It is completely about resources. It's also about whether their expertise is needed for an orthopedic elective surgery versus a critical COVID case. And so a lot of doctors are putting themselves in the front line to work in places that are outside their normal area, but which they're completely qualified for, or can become completely qualified to handle, to better use their services. So if you want to better use your service, I still say, look for ways to volunteer in your own communities, and not to see clients, because like Ruth said, we all need a massage right now.
Yeah, we all need a massage.
Yeah.
I love my roller. Totally in love with my roller right now.
That's
And my
right.
ball, I'm sitting on my ball when I'm on my
That's right. Yeah.
desk. Yeah. Oh, I'm doing everything I can.
Yeah. Yeah. And we can send emails to our clients that say, hey, I found a stretch for you online. And there's ways that we can still communicate with our clients, support our clients. I had a client call me, hey, I have this going on. What are some of the things I could do? So I just kind of
Nice.
walked her through some things. So there are a lot of ways that we can continue to support our clients, and we need to reach out to them. We need to be communicating with them. We need to be supporting them. And that opportunity is really there. It really is.
Yeah.
And there's going to be a big party.
Yeah.
Yes. Many big parties.
Yeah.
In socially distant spaces.
Yeah, right. It was funny. I was walking on the beach with some other dog walkers the other day, and we were all maintaining our distance,
Yeah.
right? But it was the biggest crowd. I mean, there were like 5 people, and it was the biggest crowd I'd been in. And I was like, I got to get out of here. This is way too crowded.
Right.
Yeah. Yeah, that's a whole other piece that we're going to have to start talking about, is like, we've been so wound up.
Yeah.
How are we going to start to wind down to even, create space for ourselves to touch people, to, bring your groceries home without looking at them like,
Right.
should I leave them in the garage for 3 days? Should
Right.
I be, like, wiping everything down? So,
Yeah.
again, I think that's why us getting prepared as massage therapists now to come back to work, so that we will be ready, as ready as we can, is such an important piece to our practice, and to continue to communicate with our clients. So,
Yeah.
wow. Anything else that either of you would like to add to this really phenomenal discussion?
I think we hammered it.
We did. I would kind of just like to say, I'm glad you came up with a positive there, Ruth, but I really do feel like this is one of those opportunities to really consider our practices and our space, and update things and investigate things and enhance our education. I think a lot of educational regulatory environments, I know in Washington, you can do everything online for the next year.
Nice.
And through 2021. So it's really a great opportunity to look for those free webinars and free educational opportunities that you can take advantage of. And so have fun.
And all 3 of us here have been involved with the World Massage Conference, which is now housed at ABMP.
Yes.
And is among their offerings. And they do a thing, I don't know, I think it's every week. They're putting up 5 popular webinars to the public. You don't have to be a member to access them. So that's a place to go and look, and they'll be so happy that I mentioned that. So
yeah, I love ABMP, and I will definitely put a link in here, and a link to the article that you mentioned with Shetao and yourself. I know you're part of that as well, right?
Yeah, I was in that too.
Yeah. So we'll get everybody's. So let's just find out your website again. Ruth is.
Oh, RuthWerner.com.
Awesome. Diana.
HandsHealEHR.com.
Fabulous. All right. Well, ladies, cannot thank you enough for what you do for our professions, and really, really appreciate your input today, and contributing to the conversation about, again, like, let's start looking forward to when we get back, and what that might look like for us. And
thank you.
We can come back in another month, and we'll have
do it
more
again.
Information. Yeah, we'll add to our information.
Do updates.
Yeah, I love you both so much.
Yeah, likewise.
Thank you.
Yeah.
Okay. Bye, Melanie. Thank you.